So 25 years ago, I went and visited this guy in the upper right-hand corner, and I thought that I would just go to, Brazil, and I'd have a nice time. I'd see Sao Paulo and I'd see Rio. I had no idea that he was going to change my life and that I was going to spend the rest of the time trying to catch up with him. He still rides that a lot better than I do. That's the first paper we published a long, long time ago. I also give Martin a hard time because he always shows pictures of his impossibly cute children. So now that I have a grandchild, I thought I'd have to put that up there. Most of my good ideas come after a little bit of food and wine and books too. But I always like this picture on the bottom because this little kid thinks this sign is so important. It's important to them, and I think too often we're standing up just spouting off things that we don't really know about, and we're not really sure what we're talking about. I always say I'm not really here to take away your plan, but I actually am. I'm here to help you change. I'm here to help you evolve. I'm here to sort of move you forward. I'd much rather be here in all these places, but this is sort of what we got. So I'm talking about prone versus lateral, not just lateral. So we're trying to compare when do we do prone, when do we go lateral, and how did I start in lateral and end up in prone? And I think that lots of times that's really easy to answer that question if you just promote and pick the right questions. So we always look for answers first. Everybody talks about those things over on the right, which are the answers, but the questions are really how we get there. And I think the questions are much more important. And I probably could stop after this slide, to tell you the truth, because I think these are the things that we really look for in surgery. So what are the questions we're asking instead of trying to provide the answers right away? How do we promote lordosis? Well, that's easy. You put the patient prone. You get 5 to 7 degrees just free by putting the patient prone. So why would you give that up in lateral? How do we maintain correction, prevent subsidence? Easy. Large grafts, anterior column support, which is what all lateral is about, right? Posterior support, being able to do that very, very easily. Put in pedicle screws. You don't have to stand on your head. You don't have to lean sideways. You don't have to rotate the patient. So doing it prone is how we were thought about doing it. It's easiest. Then at 5-1 is the real problem. So what do you do at 5-1? And someone asked a question earlier about lordosis and 5-1 and cages. And I would tell you that is the primary advantage of doing something lateral in the lateral position and getting a lateral ALIF. And anyone that tells you they can compete with that, I don't think they're telling you the absolute truth. What I can do is I use a multi-cage T-lift. I put 3 cages in. I prevent subsidence postoperatively. I gain what I get from lordosis. I do a minimally invasive T-lift or a PLIF. But I would tell you that if 5-1 is your problem and you're looking for lordosis at 5-1 out of proportion to what you have, then it's going to be really tough to get that with a T-lift. But I can prevent subsidence afterwards. How do we reduce complications? Streamline, speed up the surgical procedure. Someone just showed a case, I forget who it was, an OLIF, 1 level, pedicle screws. They said it in 2 hours. If you looked at the timing, it was an OR, or it was Martin. The OR was supposed to start at 7:10, and he made skin incision at 8:39. So I think you should count that in the time for the patient, because all the positioning time and everything you do takes time to get there. You turn the patient prone, you position them prone. It's easy, fast, and everybody knows how to do it. So speeding up and utilizing navigation. Yeah, absolutely, you can put that pin in the iliac crest. You can work sideways. You can put in pedicle screws in the lateral position. You can do a T-lift standing on your head if you want to. But the reality is, it's 100 times easier to do that when the person's prone. The best comment I ever heard was right here. It's much easier to do a lateral surgery in the prone position than it is to do posterior surgery in the lateral position. And that's what I always try to remember when I'm doing it. So, simplifying decision-making. You're going to run into some case that you're doing where you can't do what you set out to do, right? I'm down there. I planned this great case. I like the scoliosis patient we showed earlier. L1 to L5 lateral. I'm going to get this great correction. Everything's going to go great. But That's not going to happen every single time. And when you have a problem and you're in the prone position, you can easily release the facet joints, you can easily gain lordosis, you can easily decompress the patient posteriorly. So it really simplifies your ability to make decisions because you have options. So I would say for all these reasons, think about why you're doing that and then go from there. And I do think that toxification is a new word. It's something that people talk about with our current political process. You know, we're not really discussing ideas anymore. We're branding people as good, bad, left, right, instead of talking about ideas. And I think sometimes we sort of look at these procedures as company and surgeon specific, which is exactly what I'm doing right now. I'm talking about PTP versus LLIF versus OLIF, and Louise is going to talk about something later. The reality is that if you look down at the bottom, these are all the sharks swimming around you. And Neil is going to come up right there, and he's going to scare you with all those cases that he does, and he's going to show you the last 200 levels he's done since last week and all the patients he's operated on. But the fact is, I think if we look at this in a different way, we're doing ourselves a better service as surgeons. So I would like to take what I consider a patient-centric approach. Now, of course, my patient-eccentric approach is going to end up exactly where I want it, doing prone and doing a PTP. So I apologize for that ahead of time. But let's talk about what a patient-centric approach is and what are you asking. The first thing is, what are you doing, right? What level are you operating at? That makes a difference. What side are you coming from? That makes a difference. And then why are you doing the surgery, right? Do you need to gain lordosis? Do you need posterior access? Are you doing a standalone case? Do you need to do a decompression? Can you rely on indirect decompression or direct decompression? What's the correction that you need at each level? You know, it may be that you have to do an ALIF at L5-S1 because there is no better procedure at 5-1 to get correction than an ALIF from the front. And if anyone tells you different now, we're certainly working on things that are going to change that around, but that's a long way coming. And then how do we easily do fixation, right? I mean, it's pretty easy to do fixation when the person's prone. And I learned actually from around here that from looking at everyone's cases, pretty much make an incision midline, pull the skin over. It doesn't matter what the incision likes. What matters is what you do when you're inside. And then where are you working too, right? What are your facility's resources? So I have people that are doing, surgery and you just need a fluoro machine, but do you have a bed? Do you have navigation? Where are you doing this? How long can the patient stay in the hospital, right? If you have a problem, where do they go and what happens? And then management of complications. What do you do if you get a vascular injury in the ASC and you don't have a vascular surgeon within 200 miles, right? And then it's a real problem. So I think people have to think about where they're operating. Do you have navigation and robotics? Because the reality is, the reality is that the navigation and robotics is cues. Now, all I did was search an AI to tell you what the complications were. I would say that this list of complications is certainly not extensive. I didn't research. I didn't do any work on it. I just plugged into AI, and they spit out. I always look at it as nerve, vascular, and abdominal complications. And each one of these procedures has a set of complications and risks. If anyone tells you they never have a problem, then I think they're really not telling you the truth. But the thing that we always forget about is that TLIF and other procedures have lots of risks too. They have CSF leak risks. They have all kinds of risks that we don't think about, including pseudoarthrosis and other things. So everything we do has risk, and how do we manage that for each procedure? So this is a case we did last week. I think, to me, this is a good case to look at. It's a patient I've had for a long time. I did not recommend the stimulator, but it got in there long before I saw him. He's had an ACDF. He's had a couple laminectomies, and now he's got pretty mild adult degenerative scoliosis. But what level are you operating on? So we go back to the what level are you operating on? And I think that becomes important because really you want to think about what's the anatomy at the level that you're operating on and how is it critical? Do I need to do something where I come in and avoid the psoas muscle or avoid the lumbar plexus or avoid the vascular structures? And the fact is each level looks a little bit different, right? So here you're at 2-3, the vessels are midline, your plexus is posterior, You've got a kidney in the way of the retroperitoneal space, but it's no problem to get there. You don't need a posterior decompression. You're going to go from the right side, as I know Martin always says he goes from the left side. How much lordosis do you need for this case? And we averaged it at about 10 degrees. And the reality is, I think this is a level where you can do a direct access, 90 degrees from the side. It's very simple. You go trans-psoas. No one's going to bat an eye on that, and you're not going to have any trouble for all those reasons. So each level that you operate on makes a difference. 3-4 is really the same. Do I need to do a decompression? What's the retroperitoneal space like? Which side can I go from? And the fact is the right side is preferable in this case because of the scoliosis. I can go directly lateral. I can go through the psoas muscle. I don't need to dissect anteriorly. I don't need to avoid any lumbar plexus. And it's so much easier to work directly lateral, straight up and down the tube, not at an angle, and start out in that direction. What happens when you get to 4-5? Okay? So in other words, here the vessels are moving a little bit laterally. Are we heading for the 50-yard line? If you look at that, you might see, and again, I think that although you can see some of the lumbar plexus and it's starting to creep in front of you, you have space on the left in front of the psoas muscle, but you want to do the other side from the right. So now you're sort of stuck on the right. If you're going to do this prone, you're going to get about a 15-degree cage. You don't really need a direct decompression of this head. And so what I do at 4-5 now is sort of a new procedure that I call the prone angled trans-psoas, which we'll talk about in a second. And then we're at 5-1. And again, for me, if I have a low PI patient like this person is, I need about 30 degrees of correction. My sagittal balance is about 7 to 8 centimeters off. This is someone that's ideal for this procedure, and I can easily prevent subsidence and get some nice distraction. And this is sort of what we end up with at the end of the day. We take out that stimulator and then put it back in at the end. We can gain about 30 degrees. I think that the preformed rod, a unit rod, is great. As someone talked about earlier, I do a facet fusion or a posterior fusion at the levels above where I don't want to do a lateral. I certainly could have done a lateral at 1-2 in this case, but it was quite easy to do those levels. And I think this works out really, really well. It's a PSIS pin posteriorly. You spin, you navigate, plus minus for me for the robot, a nice correction, and I think people do really well from that. So this really comes from Louise. He sort of talked about table rotation technique at 4-5. And I think this blends the two procedures really well together. So in other words, what I usually start out is I start thinking about angled trans-psoas. So if you look at the middle screen, we're sort of diving in there. I'm coming down through the front of the psoas. I'm angling. I still have the patient directly lateral, directly in the prone position. But with navigation, I can identify that spot. I usually pre-plan that when I'm doing that. It's almost impossible to do this with fluoro. You can't get there. And so you look on the CT scan, you get about 15 degrees, and then you're in a good spot. But when you get down to actually doing the surgery, which is the middle piece of it, I don't see any reason, and that's why I call it the navigated table rotation or a prone angled trans-psoas. I am really hopefully taking the best parts of the O-lift, direct lateral X-lift, patient's prone, coming in just in front of the psoas muscle, avoiding the lumbar plexus, avoiding the vascular structures, using navigation to get to that point. Now, I can easily dock where that green line is, and in fact, that was my plan. But so often I end up farther anteriorly through the anterior part of the psoas and in that spot. And so it's very, very easy in that spot to get down to there. And then I can very, very easily use my navigation piece. This is another case from the left side up on top. I'll go through the anterior portion. This is my plan beforehand on the blue line on the top. The reality is you don't need to follow along that. I first started off shooting for the 50-yard line, but with a 2-bladed retractor. As you can see in the fluoro on that side, I can dock very far anteriorly, take advantage of avoiding the lumbar plexus if it's a problem, avoid the psoas muscle, and then I put the shim in that spot. I put my anterior shim in, I expand my posterior blade, posteriorly, and I then put a posterior shim in, and I rotate the retractor to 90 degrees. And I think you get the advantages of all those procedures, especially at 4-5. I don't think it's necessary at the other levels. I think we're kidding ourselves if we don't think each level is different anatomically. And I think we should think about how we operate on each level and what the advantages are for prone. And this is sort of the cage that ends up there. And again, this on the bottom is, you can put 2, sometimes 3 cages in there. I can get great distraction. You gain about 7 degrees of lordosis in the study that we're looking at in that spot. And that's sort of where I like to end up now. And I think at 4-5 especially, it makes a difference. So we sort of talked about each level is different, so my procedure gets tailored to each level, and it gets tailored to what the patient needs. So why am I doing it? And the reality is, if you're going prone, you get a lot of other advantages just from that position. Psoas changes its location. It starts to move a little bit posteriorly and gets out of your way. The plexus moves posteriorly. The peritoneum falls anteriorly and gives you more space to work in. You can absolutely gain lordosis very easily in the prone position. That's why prone surgeons have an advantage over us. So don't forget, you want lordosis, you want space to work in, you want to move the lumbar plexus away from you, and you've got an excellent, excellent opportunity when you position the prone and when you push a frame. And in addition, the iliac crest moves farther out of the way, so 4-5 access becomes very easily. Familiar position takes 10 or 15 minutes to position the patient. Simultaneous access is nice. Better access to 4-5. Coronal bend with a table in there correcting it. And these are sort of all the things that you get from going prone as compared to doing lateral surgery in the lateral position. But I always go back to the point that it's much easier to do lateral surgery in the prone position than to do posterior surgery in the lateral position, especially with navigation. And the fact is, you gain, this is a study which we sort of looked at what you gain when you put the person prone in segmental lordosis as compared to a lateral surgery. These are standard cages in some of them. And so really what you get is you get about 2/3, whereas if you're in the lateral position, you get about a little bit less than half. And then you gain the advantage from the person being prone. You can reduce the patient prior to doing the lateral, which is very nice when you're doing it. You can either do that with positioning or you can do it with distraction. And that's really nice to be able to do that. And this is a multi-center study, which you can see a lot of people were part of. Louise is on there. And the reality is, looking at the prone complications, there really are pretty similar to what you would expect. You definitely have some anterior thigh numbness. The vast majority of those, 75%, are mild. And the reality is, if you do this with neuromonitoring, and you follow along, you position the patient appropriately, and you are careful in using the docking technique, persistent radicular palsy is really dropped to 0.5%, femoral nerve palsy 0.5% in that location. So you really have gone that very far, and the reality is no increase in other complications when you turn the patient prone. So the reality for me when I'm doing it is, number one, ask the right questions. What level are you operating? Why are you operating? And where are you operating? And those things give you an advantage when you're talking about prone because you're managing your complications. So, and what do I like about doing that? Simultaneous, very simple procedure. It's almost impossible to do that when the person's in the lateral position. You get single position surgery without the trouble. Positioning lordosis, again, and also time. Right? I mean, the reality is you turn someone prone, it takes you 5-10 minutes to do it instead of taping the patient down and really working at it. Psoas gets rid of your neural complications. Your retroperitoneal space enlarges. I really like the idea that this is easier for decision-making and instrumentation. Because you're going to do a case, you're going to run into problems sometime. I can't get lateral, something happened. The patient had surgery that I didn't know about, which is you see people who video visit for the first time and they come in to see you. They said, oh yeah, I forgot. I had a bowel obstruction. I've had 3 separate surgeries, and that's going to happen to you. So how do I How do I manage that? And the reality is you can always do a T-lift from that side very, very easily when you're prone. I really like the idea of a multi-cage, which allows us to really prevent subsidence postoperatively. We looked at about 50 cases in that with multi-cages. The total subsidence is still significant because you're really talking about intraoperative subsidence, but postoperatively, 2 cages are the same as an ALIF cage, and in fact, the surface area is slightly larger. And the reality is you can use direct versus indirect decompression when you're prone. You can preserve all those advantages, and I really think that the neuromonitoring is absolutely critical. When you follow along with the neuromonitoring, if you do that safely and carefully, you can do this with a very, very low chance of any neurologic problems. And I put that in bold because Martin already talked about it. The reality is about 50% of people in the world now in a mature practice are using some sort of navigation. If we can't make this procedure navigation friendly from beginning to end, they're not going to be doing it in 10 or 15 years. And it's very, very easy to do it when you're prone. I use robotics in exactly the way you're not supposed to. I use it to try to keep up with Martin because he does every case like that. So I use it occasionally because the residents tell me it's so much faster when you do it. And then I say, I don't really like it. And then I spend another 6 months and then I do another case. So don't look at me for the robot. But I absolutely think if we can't continue to advance that, you're going to run into trouble. So think about the patient. What level am I operating on? What are the risks at that level? Why am I operating and where am I operating? And I think what you'll come to find out is turning the patient prone makes it access very, very easy, and start thinking about sort of the Luis Pimenta technique of table rotation, which with navigation, I call it the prone angled transpsoas. With navigation, and I think that's a good way to sort of mix the two procedures and avoid any problems with the lumbar plexus. Thank you. Any questions? Yeah.
I've got a question regarding in this particular case, the crest comes down just below the superior implant of L4.
Uh-huh.
And to me, that would be an easier pronatal approach to do. But what happens in the case where the crest goes a little bit higher, just to the level that this space of 4 or 5? In my hands, I've never been able to do it pronatal.
Yeah. So if you look at the literature, and Louise, I know, did an excellent study. You might be showing it later about looking at access to 4-5. So access to 4-5 with the legs slightly extended and a little bit of coronal bend in the table is actually better when you're prone than it is in the lateral position. Because when we started, I took out a couple pictures of us putting people like at 80 degrees in the lateral position, thinking that was going to open up the space. And the fact is, it doesn't really open up the space, especially at 4-5. So the best way to access 4-5 is the prone position, in fact. And there's a couple studies looking at that. The second thing is, there are also instrumentation that allows you to get down there. So there's a lot of angled instruments that you can get down there and work at. And whoever just showed a case, I think it was Rod that just showed a case, you saw those angled inserters that he had. Those were like 20 or 30 degrees. Use the angled inserters and all the angled instruments, and you really can get in there very, very easy. And I don't think the iliac crest is a problem anymore. The time that people call me and they say I had a problem, if you look at the film, it's almost always a transitional level. So they've counted 5-1, there's an S1, S2, there's a transitional level, the vessels are wide, the psoas muscles have split, the lumbar plexus is anterior, and you should not, which is exactly this case here. You really shouldn't be doing it. So look at your anatomy in the retroperitoneal space. You're going to say something?
Can I complete a little bit the question? Instead of asking the crest is high, you should ask what is the contraindication of 4-5, right? And the contraindication of 4-5 is not the lateral X-ray that shows the crest high or not, is the AP MRI. And why is that? Because we learned in the past that when you see the Mickey Mouse style of psoas muscle, you start thinking that this is a transitional level. And recently we did a study that because we have right now the patient in prone and with the leg extended, the muscle comes
posterior.
backwards, right? And as the muscle comes backward, they will not be anymore a Mickey Mouse. The problem is where are the vessels? So it's not anymore the Mickey Mouse that tells you that it's a contraindication, are the vessels. If you see the vessels on the lateral, going lateral to the vertebral body, this is a contraindication. This is a real transitional level. So the contraindication is transitional level. How is the MRI? So forget lateral X-ray, forget to see where the crest is, touching the disc 4-5 or above the 4-5. We learned that with a positioner, we move the crest 25 degrees. So it's possible to do everything, but the risk are the vessels, not the psoas muscle, not the plexus, the vessels.
Good, yeah.
Bill, that was really good. Amazing. It's become so far with lateral, it's ridiculous. But let me ask you this. Now that you're done prone, would you ever go back to doing a lateral transpsoas? Would you ever choose to do a lateral transpsoas?
Yeah, so I think when you sort of look at that, I thought someone might ask that question because the reality is we sort of talked about going transpsoas, and I think it matters what level you're at and what it looks like. So I think we become sophisticated enough to say, I can go, we'll call it directly lateral because everybody knows what that means, although no one really does that. We can call it an X-lift, we call it 90 degrees, whatever you want to. But I do think at what level you're at makes a difference. And if you're at 2-3, it's so much nicer to work orthogonally from the very beginning. I don't think you have to worry in that case. And the vessels are out of the way, the plexus is posteriorly, especially when they're prone. And I really think that docking situation makes it so much easier. With a two-bladed retractor, you could dock in any location you want and then open the retractor. But I do agree with you. I have gone now, especially at 4-5, and we stimulate now in those levels, and we're greater than 20 milliamps almost every single time because the plexus is posteriorly. And I've gone to more anterior with the prone position, using navigation to do that, and then opening posteriorly, which you've been doing at every level for a long, long time.
Thank you.
Yeah, but the difference is through the psoas muscle.
Yeah. So we'll come down. So we still do that. And I would say in the paper that we showed, I mean, the reality is transpsoas, neuromonitoring, looking at the level, a mature practice, your persistent femoral nerve palsy should be way less than 1%. All right.
Cool. I think we got a break right now, right? A small break for 15 minutes.